अच्छा, लाइट सेट होती है। नहीं, एक बार ऑन करो, ये कैमरा सेट कर देते हैं। डिले आता है क्या?
15-20 सेकंड सर वो लेट आता है।
अच्छा अच्छा, एक बार छोड़ो। ओके। स्टूडेंट्स कैसे दिखेंगे? कैसे यहाँ दिखेगा?
इस पर आएगा सर, यहाँ पे जैसे 1 2 3 कितना आते हैं लोग।
अच्छा। तो आप अपना मोबाइल छोड़ दो फिर यहाँ पे चलेगा। रिकॉर्डिंग किस पॉइंट से शुरू होगा?
रिकॉर्डिंग तो सर उधर ही होता है सीधा ही।
अच्छा,
टेलीमेडिसिन में।
अच्छा, लेट आता है इसका ना?
20 सेकंड आएगा सर।
अच्छा, ओह।
आना शुरू हो गया सर। अगर आप बोलेंगे ना कि भाई कौन कौन स्टूडेंट है तो अपना वो लिख के देंगे।
अच्छा, तो यहाँ कुछ नहीं आता है ये बताने के लिए?
नहीं, इधर कुछ नहीं, सब वो इस पर आएगा। ठीक है।
अच्छा, यहाँ कुछ नहीं आता है ये बताने के लिए?
वो इस पर आएगा, यहाँ पे दिखाता हूँ इसमें।
तो जब मैं पावर पॉइंट कराऊंगा तो नहीं पता चलेगा?
नहीं, वो सिर्फ ये इस पे दिखाएगा, मोबाइल पे दिखाएगा तो सीधा ये।
अच्छा, फिर मोबाइल छोड़ दो आप अपना।
जैसे दिखा रहा है ना।
हाँ हाँ, साउंड बंद कर
साउंड
दो।
इस पे
मोबाइल का साउंड बंद कर दो।
छोड़ा।
Good morning, students. Can you introduce yourself? एक मिनट देखो, आ तो रहा है क्या? बिकॉज वो दिख तो नहीं रहा है, उस पे स्क्रीन पे तो नहीं आ रहा है। स्क्रीन पे तो पावर पॉइंट नहीं आ रहा है। अच्छा भाईगा, तो ये 5 स्टूडेंट्स हैं, शुरू कर दें फिर हम?
हाँ
राइट, ओके, ऐसे ही आएगा ना?
हाँ जी।
ओके, ठीक है, ओके, राइट।
11 बजे? 11 बजे?
हाँ, 11 बजे। Okay, good morning, students. We can start the today's session. We are going to discuss management of low birth weight infants. So the concept of low birth weight infant is not at all new, and people even in 18th or 19th century realized that the babies who are born before time have higher risk of morbidities and mortality. But since people were not capable of measuring gestation precisely, so they measured prematurity in terms of birth weight. So they defined prematurity like less than 2500 gram or less than 2 kg or less than 2.2 kg. They defined in a different ways. But the concept of low birth weight finally took its roots when this gentleman named Arvo Henrik Jelpo, who was a Finnish pediatrician, and this person gave the today's definition of low birth weight, meaning the birth weight below 2500 gram, and since then this concept has stayed. Though we know that the better predictor of mortality and morbidity is actually the gestation at birth and whether there is an IUCR or not, whether the baby has grown properly or not. But because of the difficulty in the measurement, the concept of low birth weight stayed, and it served as an important surrogate of gestation and IUCR. But as we move on and as technology progresses and our level of care improves and we are able to measure gestation precisely, the gestation and fetal growth would replace the concept of low birth weight. But in foreseeable future, because that's not going to happen so soon, the concept of low birth weight is going to stay with us. So in today's talk, we are going to discuss the definition of low birth weight, types, magnitude and etiology, how we can identify these at the hospital setting and at the community setting. We will touch upon the issues like the antenatal management, resuscitation, temperature, fluid and feeds, managing different morbidities, infection prevention, empowerment of the mothers and families, discharge and follow-up. As you can see that this practically covers the entire newborn teaching for the semester. So a lot of things would be covered in the other lectures, and I'm going to touch upon the issues that would not be covered by the other topics. And then of course we will look at the outcomes of low birth babies and couple of key messages. Coming back to the issue of definition, we just discussed, and I'm quite sure you know it, that when the birth weight is below 2,500 gram, then it's low birth weight. Exactly 2,500 gram is not low birth weight, that's a normal birth weight. So low birth weight means less than 2.5 kg, and the incidence of the low birth weight in India is approximately 30%, means 1 in 3 babies is born low birth weight. Why low birth weight is important? We know that 75% of neonatal deaths, so they are 30% of the total births, but if you look at the neonatal deaths, 75% of neonatal deaths are happening in these babies, and 50% of infant death, that means death before 1 year. So low birth weight not only predisposes to increased mortality and morbidity during newborn period, but this continues during the infancy and even beyond infancy, and in fact beyond even childhood. So they account for 50% of infant death, and therefore the concept of low birth weight, or identifying the low birth weight babies and managing them properly, are very, very important. Also, low birth weight babies are more prone to malnutrition, recurrent infections during neonatal period and beyond. There is a higher chance of neurodevelopmental delay, and also now there is a concept that if the babies are born low birth weight and if they are now subjected to a situation of nutrition sufficiency, because they have maladapted themselves to a lower level of nutrition, and once they come out and if they find plenty of nutrition, then that optimum nutrition becomes too much of them, and consequently they develop adult onset diseases like diabetes, hypertension, coronary artery disease and obesity. You would have a talk by Dr. Rajni Sharma on this issue, so I would not touch upon that issue. Coming to types of low birth weight, you know that low birth weight is not a homogeneous group, it's a heterogeneous group. You have different kind of babies, mainly two types. So there are babies who are preterm, that means those who are less than 37 weeks of gestation, and then there are babies who are term but small for dates, means they had intrauterine growth retardation, growth restriction. That means if you look at their growth on the percentile terms, in terms of percentile, then their growth is less than 10th centile. So low birth weight babies, 2/3 of them are term low birth weight babies, term IUGR babies, and 1/3 of them are preterm babies. Many of the preterm babies may be weighing 2.5 kg or more, so they may not be low birth weight. So not all preterm babies are included in low birth weight, it's by weight. Now coming to a different kind of classification which divides low birth weight babies further depending upon their weight. So we have all the neonates, let's say this is the entire population, and approximately 30% of them would be below 2.5 kg, so therefore they are low birth weight. Within that group, there is a smaller fraction of babies that weigh less than 2.5 kg, and that's a small proportion. So if these are the 30%, then of the total population, 2 to 3% means 10 to 20% of low birth weight babies would be born as very low birth weight, VLBW. That means their weight is below 1.5 kg. 1.5 kg is not very low birth weight, it's below, less than 1.5 kg. And within that, there is a smaller fraction, which is maybe less than 0.5% of the total population, means approximately 2 to 3% of the total low birth weight babies that weigh less than 1 kg, and they are known as extremely low birth weight babies. So therefore, we have, based on weight, we can have low birth weight. Within that subgroup, there is a babies that weigh less than 1.5 kg. They are known as very low birth weight babies, and a very small fraction of them weigh less than 1 kg. They are extremely low birth weight babies. Similarly, we have classification by gestation also. So you have less than 37-week babies that would be preterm babies. Within that, the babies who are less than 28 weeks, means 27 weeks or lower, would be extremely preterm babies. The babies between 28 and 31 weeks of gestation would be very preterm babies, and babies between 32 and 33 weeks babies, these babies are known as moderately preterm babies, and 34, 35, 36 weeks babies are known as late preterm babies. Not all of them are going to be low birth weight. Many of the babies, particularly at gestation 35 and 36, might be 2.5 kg or more. So when we look at, now let's look at all the low birth weight babies from the gestation and birth weight angles. So the babies who are between 2 and 2.5 kg, they are likely to be term low birth weight babies. That means they are term growth restricted babies. Between 1.5 and 2 kg babies are likely to be preterm, between 32 and 36 weeks of gestation. And the babies who are 1 to 1.5 kg, these babies are likely to be preterm, less than 32 weeks of gestation. And the babies who are less than 1 kg, then these babies are likely to be less than 28 weeks of gestation. So I think it is important to remember this corresponding gestation to the birth weight, because that would help us you to determine different kind of management that these babies might require, and also anticipating the morbidities that these babies can suffer from. Now let's look at the causation, what causes prematurity. So this is, is a very, very vast topic, and we cannot go in detail, and this is an area of intense research, that what causes prematurity, because if you can prevent prematurity, you can really prevent a lot of morbidities and hospital stay and the agony of the family and the babies. So there is a lot of work that's going on prematurity. Right now, there is no major breakthrough, but we can expect something happening in the future. Currently, the risk factors of prematurities are low maternal weight. Teenage pregnancies are a very important risk factor, multiple pregnancies, history of previous preterm birth, cervical incompetence, any acute obstetric complication like antepartum hemorrhage, or any acute medical disease. Mother is fine, she develops acute hepatitis and can go in preterm labor. Induced preterm delivery because of either fetal or maternal indication is an important cause of prematurity, and in many cases we are not able to identify any risk factor. Similarly, for the term SFT babies, the risk factors are poor nutritional status of the mother, chronic illnesses like hypertension, toxemia, anemia, multiple pregnancies, um, post maturity, diseases like malaria or asthma or chronic renal disease, smoking. So these are important factors for causation of or the risk factors of term low birth weight babies. You can see that some of them are common. So therefore, there are risk factors or possible factors that can influence the duration of gestation as well as the fetal growth. So how do you identify the low birth weight babies? For prematurity, we can look at last menstrual period of the mother if she remembers, and if that is there, then that is, and if the mother's period was regular, then that's taken as the gold standard. If that is not there, then one can look at the first trimester ultrasound if that information is available. And the first trimester ultrasound, there are various parameters, and you can measure the duration of gestation with fairly good precision. If that is also not there, then you can examine the newborns. There are elaborate scoring systems like expanded new Ballard score, but the scope of the lecture is not to cover those elaborate things. But you can do physical examination based on certain physical parameters like breast nodules, genitalia, sole creases, ear cartilage, etc. So let's look at the breast nodule. I'm quite sure in your postings you have seen that preterm baby would have a small nodule and the areola is depigmented, and at the gestation increases, the size of the areola increases and the pigmentation also increases, and also the breast bud would increase in size to more than 5 mm. If you look at the male genitalia, then you can see that the preterm babies would have lesser rugosities, the color is faint, the testes are not fully descended depending upon the period of gestation. And if you compare it with the term babies, you find a lot of rugosities, and then you will find pigmentations, and both the testes would be well descended and scrotum would be quite pendulous. If you look at the female genitalia, you can see that the preterm babies would have prominent clitoris and minora, and the majora would be less prominent. And in comparison, at term babies, the majora would be quite full and covering the minora and clitoris. And if you look at the sole creases, you need to look at the deep creases that are across the sole. And what you find that the preterm babies would have either very less deep creases or only in anterior third, while the term babies would have deep sole creases extending up to the entire sole, in the entire sole, or up to anterior 2/3 of the sole. So that's how you can differentiate. Also, you can look at the ear cartilage. What you see in term babies, it's a very well formed pinna. You have all the curves, and if you fold it and release it, you would have instant recoil. While the preterm baby's pinna would be less curvaceous, and if you fold and then release it, then the recoil would not be that fast. So that's how you can differentiate between a preterm and term babies. If you apply the proper scores, then you can get the gestation with a precision of 1 week, but you can broadly classify these the preterm babies into 4-5 groups based on this physical criteria. How do you identify a term SFT baby? One option is that you look at the intrauterine growth chart. So intrauterine growth charts are the charts that plot gestation on the x-axis and birth weight on the y-axis, and then you have different centiles. You have 10th centile, you have 50th centile, you have a 90th centile. And I'm quite sure you know about it, that if the weight for the gestation is below 10th centile, then that baby is known as SFT or SGA babies. Small for gestational or small for gestational age, small for dates or small for gestational age. So you can identify SFT babies by looking at these intrauterine growth charts. Also, you can look at the physical characteristics, like these babies tend to have emaciated look, an old man look. They have loose folds of skin around the leg that gives you baggy pant appearance. There is, if you look at the skin, there is overall lack of subcutaneous tissue. And if you measure head circumference and chest circumference, normally the difference is 1 to 2 centimeter, but in IUGR babies the difference would be greater than 3 centimeter. So if you find these parameters, then you can guess that this babies might be a term SFT baby. This is intrauterine growth chart. We just talked about it, and what you see is the gestation on the x-axis and birth weight on the y-axis. Any baby who's less than 37 weeks is preterm. 37 weeks is not preterm. 37 weeks is a term baby. Between 37 and less than 42, it's a term baby. And 42 and bigger, you have post-term babies. And in these era, because the pregnancy, the labor would be induced, so therefore the number of babies with gestation being more 42 or more is very less. And then you have birth weight on y-axis, and then there are this line is 10th centile, and we just talked about it, that anyone who's below 10th centile is small for dates or small for gestational age. Between 10th and 90th percentile, this is appropriate for date. Any baby whose birth weight for gestation falls above 90th centile, then those babies are known as large for gestational age babies, LGA or LFT babies. So that's how you can have total of 9 groups: preterm SGA, preterm AGA, and preterm LGA, and same for the term and post-term babies. So how the low birth weight concept applies here? So anyone who's below 2.5 kg would be low birth weight. So you can see that low birth weight baby can be a preterm baby, it can be a term baby, or it can be even post-term baby, right? So it's a heterogeneous group. Okay, for example, you have a 39-week baby who's, let's say, 2.1 kg. This baby would be term SFT baby. Let's look at this baby who's 2.3 kg, but the gestation is 36 weeks. Then this baby falls between 10th and 90th centile. So therefore this baby is term AFT or term AGA baby. And then this baby whose gestation is, let's say, 42 weeks and weight is 2.4 kg, then this baby is post-term SFT baby. So you see that all the 3 babies are low birth weight babies, but then they have different gestation and then they have different growth category, right? So therefore signifying that this is low birth weight is a heterogeneous group of babies. So these are the 2 pictures. This baby is a 2.1 kg IUGR baby, and this is a AGA baby, term AGA baby. You can see the genitalia, which is quite pigmented scrotum, and testes are well descended, right? So in this IUGR baby, you see the old man look, you see loose fold of skin, overall the slender look compared to this baby, and you see overall the less subcutaneous tissue. You can see the ribs being prominent, which is not visible here. So by look itself, you can get an idea whether the baby is term SCA baby or a term AGA baby, right? Now let's look at the problems that these babies can suffer from. And because these babies are is a heterogeneous group of babies, so therefore we have different sets of problems for preterm babies and different set of problems for term SCA babies. Let's look at preterm babies. So these babies can suffer from asphyxia, hypothermia, hypoglycemia, increased chances of infection, hyperbil, respiratory distress, retinopathy of prematurity, apnea, intraventricular hemorrhage, feeding difficulties. So this is quite a long list, and what is important is that lesser the gestation, more is the likelihood of these complications, right? So a baby who's, let's say, 31 week weeks has higher chance of these morbidities, including respiratory distress, than a baby who's born at 36 weeks of gestation, right? So the percentages of these problems would increase with decreasing gestation. Let's look at term SFT babies. These babies can suffer from asphyxia. These babies, because of intrauterine hypoxia, they can pass meconium in utero, which they can aspirate. So they can develop what is known as meconium aspiration syndrome. These babies, because have less subcutaneous tissue, are more likely to develop hypothermia, hypoglycemia, also increased infection, and polycythemia. So polycythemia is a very unique problem to these babies, because these babies grow in an environment of lesser oxygen concentration. There is less oxygen and nutrient supply, so therefore body responds by increasing the red cell mass. Coming to the management, let's look at the principles of managing low birth weight babies. So there are certain things that we can do at antenatal during antenatal period. In fact, if you look at the entire spectrum, it's a life cycle approach. So you have a low birth weight baby who would go on to become a child, a malnourished child, and he would have lesser stature, and that low nutrition continues into adolescence. And because these babies are born in an environment of deprivation, so therefore the educational outcomes and opportunities are lesser. So finally a child would become a mother, which further give rise to give birth to a low birth weight baby. A mother low birth weight would give birth to a low birth weight baby, and then the cycle continues. So it's a life cycle approach. Ideally you should be working, or we should be working at each stage, so as to break that cycle, right? But we will not be going in detail of that. But what is important is that we look at the antenatal period. Resuscitation is very important component. Thermal protection, fluids and feeds, managing morbidities, prevention of infection, empowering families and mother is very, very critical. Vaccination of the children, and discharge and follow-up outcomes. So you can see many of these principles are common to managing any neonates, and then there are more talks on some of these topics. For example, you would have a you already had sessions on resuscitation. Then there is a session on sepsis and respiratory difficulties. So we will not be covering those things here, right? Coming to the antenatal intervention, I think everything that you do during antenatal period influences the weight and gestation, intrauterine growth and gestation of the mother. So therefore best practices for managing pregnancies, and we will not be going in details, but you need to do right things during pregnancies, including managing hypertension, prevention of hemorrhages, giving nutrients, ensuring rest, etc. Decreasing the exposure to different kind of toxins, smogs, etc. Antenatal steroids, something which is very, very critical and which has changed the entire scenario for the preterm neonates, and any pregnancy which is likely to deliver at less than 34 weeks of gestation. Actually mother should be in preterm labor. So if that is the scenario and gestation is less than 34 weeks, you need to give one course of antenatal corticosteroids, and then that changes, that decreases the mortality, neonatal mortality, by almost 30 to 40%. Decreases RDS, decreases hemorrhage, decreases NEC. There are whole lot of benefits that you need to take care of. We give IV Mexelf to the mother when the when the labor is happening at gestation less than 31 weeks, because that has shown to have a neuroprotective value for the neonate. So that is given as a matter of routine. And ideally babies, the pregnancies at lower gestation in particular, and if the facility is not capable of managing those neonates, ideally you should be undertaking in utero transfer, so that the neonate gets transferred to an optimum facility where the pregnancy and the neonate can be managed much better, and in utero transfer is far better than transporting the neonate. So that is very important principle. Coming to resuscitation, we would not be talking about the general principles, but the resuscitation of low birth baby should happen in equipped centers, particularly babies who are expected to be less than 2 kg or babies who are expected to be less than 34 weeks, with skilled persons, because these babies are more likely to require higher level of resuscitation. You need more stringent conditions, thermal protection and the other requirements are more stringent in case of resuscitation of a preterm baby. And because the babies are small and it's really very difficult, you have to have the right size of equipment, and the technique that the procedures like positive pressure ventilation and intubation, they require a much higher level of skill. So therefore it is really very important that the birth of such babies are happening at a proper center. Coming to further classification of low birth weight babies, you might get confused that I am bringing too many classifications, but they have different contexts, right? The context to this classification is that we use classification, and this is based on birth weight and not gestation, but we can draw the comparisons between weight and gestation. The purpose of this is to identify the babies that would require different level of care. So it has got a different concept. So normally we divide low birth weight babies into 3 different categories. You had very low birth weight babies and extremely low birth weight babies and low birth weight babies, but we manage babies by this classification more often. So babies who are less than 1.2 kg, and these babies are likely to be less than 30 weeks, these babies tend to be very sick. They require specialized care, and ideally they should be managed in tertiary care centers. The babies between 1.2 to less than 1.8 kg, and these babies are likely to be between 30 and 33 weeks of gestation. Many of these babies would be sick, and then sickness would be a moderate level, and then these babies would require level 2 care. And then the third group of babies are babies between 1.8 to less than 2.5 kg, and these babies are 34 plus weeks, 34, 35, 36 or even 37 and more 37 or more. These babies are often stable, and you can manage them in level 1 facilities, and care is largely mother driven. You need to educate the mother. They are at higher risk of problems. So it does not mean that they do not require proper attention. They do require proper attention, but the mother driven care can be instituted these babies in the postnatal ward. And of course, I mean, this is a very broad classification. You can have a baby who's 1.9 kg who is extremely sick and require tertiary care. So I think this is a very broad classification, and this is how we categorize them for care. So for example, when you are working at a facility and delivery of a low birth weight babies happen, how do you make the judgment at birth that which baby can stay with the mother and which baby should come to your neonatal ICU or special care neonatal unit? SNCUs are the special care neonatal care units. These are located at district hospitals and sub-district hospitals, and then they are capable of, they are level 2 facilities and capable of managing moderately sick babies. So these babies should be admitted, a baby should be admitted to these facilities if the birth weight is below 1.8 kg or gestation is less than 34 weeks, or they have any sickness, and that's irrespective of birth weight and gestation, like fast breathing, apnea, seizures, shock, sepsis, significant jaundice and others. So The weight and gestation can be decided right at birth, but you may have sickness that might develop later. So some of these babies might require admission. They are, let's say, 1.9 kg baby and subsequently develops sepsis, may require admission later at, let's say, 48 hours of age. The low birth weight babies, coming to the important morbidities and principles of the management. We know that the low birth weight babies are at very high risk of hypothermia, and they can, because they are small, they have less subcutaneous tissue, they have less brown tissue, they lack the known shivering thermogenesis mechanism, they have less brown tissues, and so on and so forth, and large surface area. So they can lose weight by these four mechanisms: radiation, convection, evaporation, and conduction. I'm quite sure you know these physics principles. Radiation, when the heat loss is happening to cold surfaces that are not in contact, while conduction is losing heat to cold surfaces that are lying in contact, right? Convection is when there are air currents flowing across the baby, then they can take the heat away. And evaporation is when the baby is wet, particularly at the time of birth, with amniotic fluid, and when that gets evaporated, that they can take heat from the baby. So you need to make sure that all these four mechanisms of heat loss are taken care of by ensuring warm delivery room, and it is really very important that the delivery room temperature is more than 25. More than 25 is often not very comfortable to adult health workers. So if they are not aware, then they would switch on AC and reduce the temperature of the delivery room. May not be comfortable to the mother also, but it is really very important if you are expecting the birth of a low birth weight baby, and otherwise also the delivery room temperature should not be less than 25 centigrade, and the room should be free from air drafts. Warm resuscitation, anything that is coming in contact with the baby, be it linen or your resuscitation bag or laryngoscope or suction catheter or anything, they should be warm so that the baby does not lose heat. Immediate drying, skin to skin contact, I think this is a very important concept. So now these days, rather than even low birth weight babies and normal birth weight babies as well, if they do not require resuscitation, if they have cried well at the time of birth, we do not cut the umbilical cord, because that helps in what is known as delayed cord clamping. That gives extra blood volume to the baby, which is beneficial for them. The baby is put on mother's abdomen and be there. You can dry the baby there and then remove wet linen and keep the baby and mother together, and that's known as skin to skin contact, and that has got a lot of advantages. Breastfeeding, that provides the nutrition as well as gives heat from mother's body. Bathing postponed for at least 7 days. Provide appropriate clothing and make sure that the clothes are warm enough, because the cold cloth would take away the heat of the baby. Keep the mother and baby together. They should not be in a different cot. And you should alert the health providers if there is any hypothermia, and warm transportation if the baby requires so. So how can you keep the baby? Let's say that the baby has born at home or has been discharged at home. Then how do you manage babies at home? How do you keep them warm? So keep the baby in skin to skin contact. Prevent all the mechanisms of heat loss. Make sure that the baby is not in contact with cold surfaces. The clothes are also warm. Baby is not wet. Head is also covered, etc. And you should have warm room, either keeping the room, particularly in cold weather, by a heater or some fire, and the baby is clothed properly. I think that is something which is very, very important. A cap is provided, socks and mittens, and you provide warm clothing. You can see that babies are nicely wrapped. You have cap, and then you have nice woolen, and then you can see that the sleeves are longer than the arms of the babies, so that they remain well covered, and then you see the extra layers of clothing. So it is really very important that the babies are kept warm. Right, fine. How do we keep the babies in the warm in the hospital? So we keep the babies warm in the hospital by keeping with the mother. When the babies are in the postnatal ward, then you can apply the same principles as of the principles that we just talked about, how to keep the babies warm at home. So those same principles can be applied in the postnatal ward. In the NICU or SNCU, we keep the babies warm by putting the baby in KMC, right? This is something which is very, very important, that either mother or a relative keep the baby in skin to skin contact, and ideally that can be done for 24 hours, and that is possible particularly if you have right kind of support, and mother has got some support of relative. So sometimes relative comes, and sometimes mother comes. Sometimes the baby is sick and then you are not able to do KMC, or when the mother is not available or not able to provide round the clock. So in that case, the baby is kept in this equipment which is known as radiant warmer, and this equipment is known as incubator, right? The difference between two is that this is an open care system. You see that the baby is accessible from all the sides. This is a closed system, so you cannot access the baby, and this particular fact has got its own advantages and disadvantages. A closed system would prevent unnecessary contact, would provide a better thermal protection, would prevent unnecessary sensory stimuli, and provide a very cozy environment. But the problem is that this is a complex machine, so therefore difficult to clean. So if you haven't cleaned it properly, then it can transmit infection from one baby to the other. Secondly, if the baby is too sick and then that requires a lot of interventions, then the incubator may not be an appropriate thing to do. Radiant warmer provide a very good access, but then does not have the advantage that we have just mentioned for the incubator. So there are various ways by which we maintain temperature of the babies, and then these equipment are run in servo control. So what is the meaning of that? That we have a probe that is attached to baby's skin, and we set a temperature of normal temperature, let's say 36.5 to 37.5, and then the heater output here in the radiant warmer, and then there is a warm air that is circulated here. So the temperature of the heater output would vary depending upon the temperature of the baby, right? So there is a servo control, and the machine keep changing its output depending upon the requirement of the baby. These equipment are of course costly and may not be available at many resource poor settings. So therefore people have worked with low cost technology, and this is one of them. You see that the baby is wrapped nicely. So this is the device which is developed by an innovator. So this is known as embrace device. So this embrace device has got this is a cartridge which has got phase changing material, right? So this phase changing material, this cartridge is put in this warmer, and then this warmer heats up this phase changing material, and then you put it in this pouch, and then this gives heat for next 6 to 8 hours, and then the babies are kept warm. So this is a very nice device which is low cost, and then the mothers can handle it. Suppose the baby developed hypothermia, then what do you do? So you know that there are different degree of hypothermia. If it is less than 36.5, 36 to 36.5, this is cold stress. Between and 32 to 36, it's moderate hypothermia, and less than 32 is severe hypothermia, which is dangerous, right? So if you have cold stress, then you need to cover baby adequately. Make sure that the baby remove cold cloth and replace them with the warm clothes. Room should be warm. Provide skin to skin contact and breastfeeding. But if it is a moderate hypothermia, then in addition to this, you need to provide extra heat, like a heater in the room, or putting the baby in the radiant warmer. And if it is a severe hypothermia, then in addition to all these, we need to provide IV fluid, oxygen, vitamin K, and consider antibiotics if the hypothermia does not get corrected with the heat, right? So we manage hypothermia, and hypothermia is something which is really very important. We are now coming to the next morbidity, which is the respiratory distress. Particularly preterm low birth weight babies, and term low birth weight as well, they tend to have respiratory difficulty at birth. So I'll show you a video here. So this is a video of a low birth weight baby who has got respiratory distress at birth. So kindly see the different thing, like fast breathing, chest retractions, and grunting. This baby is grunting. Okay, right. So did you see that the grunting was happening, and baby was grunting actually, and then grunting is an expiratory sound, prolonged expiratory sound, and the baby is trying to retain his functional residual capacity. And you must have seen the lower chest retraction. The fast breathing was not as marked, so the baby had respiratory distress, right? So respiratory distress has been defined as presence of either fast breathing or chest retractions or grunting or cyanosis. Actually, there should be at least two of them, right? So fast breathing and or presence of any of these parameters means respiratory distress. And you can have many causes of respiratory distress, like you can have RDS, respiratory distress syndrome, because of surfactant deficiency in preterm neonates. You can have meconium aspiration syndrome in term neonates, and then you can have transient tachypnea, pneumonia, malformations, or pneumothorax in any gestation babies. So, but we will not be going in detail of the difficult breathing issue, because you are going to have a separate talk on that. And how do you manage this distress? You provide adequate respiratory support, you need specific treatment, and of course you need monitoring of these babies also, right? And this is a pulse oximeter, and you can see this is connected with the baby, and you need to, this provides you saturation, and this provides you heart rate, and you need to maintain a target saturation of 91 to 95%, right? Coming to the next important issues, that how to manage feeding and fluids and feedings of these babies, and this is very important topic, and we are going to spend some time on this. So feeding maturation depends on a variety of factors, and what are those factors? Like gestation. So lesser the gestation, lesser is the maturation of feeding function, and whether the baby is stable or sick. So who are unstable babies? The babies with fast breathing or chest indrawing, one with apnea, need for oxygen, convulsions or unconsciousness, or abdominal distension. So these are the babies. If these conditions are present, then the baby should be labeled as an unstable baby, and these babies should be started on IV fluids. And you start the baby, once the baby is reasonably stable, then you start them on feeds, initially in small volume, which is known as trophic feeds, and then advance, and then gradually you stop IV fluids depending upon the size and stability of the baby, right? If the baby is stable, then we look at the weight in gestation. So the first group, the weight less than 1200 gram and less than 30 weeks, then these babies have to be started on IV fluids to begin with, and we introduce gavage feeding once they are stable, and then we shift to palliative feeds over next few days, and later on to breastfeed, right? So there is a progression from IV fluid to gavage to palatate to breastfeeding, and then that's happened in all the babies. The sequence remains the same, but baby can start at maybe gavage. If the baby is little bigger, then he can start at palatate, and if the baby is mature enough, then he can start direct breastfeeding also. If a baby is stable, then you need not give IV fluid, because many of these babies are sick and small also. But if they are, let's say, 28-29 weeks and absolutely stable, then they may be started on gavage as well. The babies between 12 and 1800 gram and between 13 and 34 weeks, you start them on gavage feeding, and then you start them on katori spoon feeding. The higher gestation, let's say 32, 33 or 34 weeks, would be able to start katori spoon or palatate feeding pretty fast, and 29, 30 week, 31 week might take a little longer. And if they have some sickness, then there might be some delay in that transfer. Shift the baby to breastfeed as soon as the baby is able to stable. So you can see gavage, katori, and then breastfeeds, and these categories serve as a broad categories, right? And you look at the capability of the baby. So you begin with the gavage and then keep testing whether the baby can accept palatate, and if the baby is accepting palatate, you keep testing whether the baby can accept breastfeeding. And there would be time when there is overlap, like the baby is on gavage as well as palatate, or palatate as well as breastfeeding. The babies who are more than 1800 gram and more than 34 weeks, they can be directly started on breastfeeding. But some of these babies may require, in addition, palatate feeding also, if the sucking is not satisfactory and baby is not able to accept adequate amount of milk through breastfeeding. And you shift the baby, these babies can be shifted on total breastfeeding as soon as you judge that the baby is taking enough amount of milk and growing well, right? So now I'm going to show you a video. I hope that you saw a couple of videos that I had provided on Saral platform. If you haven't, then kindly see, there are 8, 9, 10 videos, and each video is just 2-3 minutes, would not take you long, but then that would will give you a lot of information, and I'm quite sure you would enjoy. One of these videos is on gavage feeding, so let's look at that. So we are going to look at the insertion of orogastric tube and gavage feeding.
We shall demonstrate the procedure of insertion of the nasogastric tube and the method of intragastric tube feeding. Intragastric tube feeding is indicated in stable, low birth weight babies who are not able to accept breastfeeding by palatate or katori spoon. For intragastric tube feeding, you would require feeding tubes, syringes to measure the correct amount of milk, a stethoscope, measuring tape, and scissors. 2 different sizes of feeding tubes are required for feeding newborn babies. Size 6 French is used for infants weighing more than 2000 grams, while size 5 French is used for babies weighing less than 2000 grams. Before inserting the gastric tube, first wash your hands. Then estimate the length of insertion by measuring the distance from the tip of the nose to the earlobe and then onto the infant's abdomen just below the rib margin. Note the reading on the orogastric tube. There is no need to routinely lubricate the tube. Flex the infant's neck slightly. Pass the tube gently through the mouth. Once the required length is inserted, fix the tube with the adhesive tape. Check the position of the tube. Take air in a 2 ml syringe. Place the stethoscope over the abdomen. Now, quickly push the air down the tube and listen for the sound. The second option is to check the position of the tube by aspirating the contents of the stomach and to see if it looks like curdled milk. After you have confirmed the position of the nasogastric tube, Start giving feeds through the tube. Measure the required amount of milk using a clean syringe. Remove the plunger of the syringe. Connect the barrel of the syringe to the end of the gastric tube. Pinch the tube and then fill the barrel with the required volume of milk. Hold the syringe above the infant. Release the pinch and let the milk flow through the gastric tube by gravity. Do not force milk through the gastric tube by using the plunger of the syringe. Cap the end of the gastric tube after giving feeds. Store the syringe in a clean and dry container for next use. The syringe should be changed in every shift. Thank you.
Right. Okay. Now let's look at the another video on the palliative feeding.
In this video, we shall demonstrate the procedure of pulmonary feeding. This mode of feeding serves as an intermediate step between gavage feeding and breastfeeding. Babies with a gestational age of 31 to 32 weeks with limited sucking and swallowing coordination can be fed by this method. Take the required amount of expressed milk in a bowl. It is recommended to hold the baby in an upright posture in order to avoid aspiration. The infant should be awake. Fill the pulmonary spoon with the milk. Hold the pulmonary so that the pointed tip rests lightly on the infant's lower lip. Tilt the pulmonary to pour a small amount of milk into the infant's mouth. Feed the infant slowly. Make sure the infant has swallowed the milk already taken before giving more. If the baby does not actively accept and swallow the feed, try to wake the baby with gentle stimulation. If the baby is sluggish, do not insist on this method, but switch over to gavage feeds. When the infant has had enough, he or she will close his or her mouth and will not take any more. Do not force feed the infant. Burp the baby gently by holding upright. After use, wash the utensils thoroughly with soap and water and boil for 15 to 20 minutes. Alternatively, the utensils can also be autoclaved. Thank you.
Right. What to feed? So we just saw how to feed. Let's look at what to feed. So breast milk is the best. There is no doubt about it. It can be given either direct as direct breastfeeding, or you can express milk and feed the baby by either palate or tube. Suppose the mother's own milk is not available, then the second best choice is pasteurized donor milk. And for this, there are now milk banks that are coming where mothers donate the milk, and that can be used for sick and small babies. The third option is low birth weight formula, and then these are the three important options. Animal milk like cow's milk or dairy's milk is the last choice. We tend not to use it. How much do we feed? And this chart gives you the fluid requirement, and we look at two groups of babies, less than 1500 gram and more than 1500 gram. In less than 1500 gram, we start with 80 ml per kg on day 1 and then go on to 150 ml per kg on day 7 or so, and the increment is approximately 15 to 20 ml per day per kg per day. And for more than 1500 gram, we begin with little lesser amount, that is 60 ml, and then but the maximum requirement is the same and increment is also the same. So it's the beginning, the starting point, that's different. So the next again there is a video because you know that if the baby cannot accept direct breastfeeding, then the mother has to express it, and that's an important skill that mother has to learn, and you as a provider have to teach the mother how to express milk.
Consumption of breast milk is indicated in mothers whose infants are not able to breastfeed, but at the same time are able to accept oral feeds either by a maladie or by intragastric tube. Breast milk can be expressed either manually or by using breast pumps. Manual expression is the preferred technique. For manual expression, we require a clean, wide-mouthed, sterile container. Before expression, wash your hands with soap and water. To prepare the container, wash it as well. Put the container in boiling water and leave it there. Simultaneously, tell the mother to sit comfortably in the room and think lovingly of her baby. Hold the container under the nipple and the areola. Now, gently massage the breast. Place your thumb on the top of the breast about an inch or an inch and a half away from the nipple, with the first finger on the underside just opposite to the thumb. Note that the fingers are to be positioned so that the areola lies in between the thumb and the forefinger. Now, push the thumb and the forefinger together towards the chest wall. Roll them forward at the same time. This rolling motion compresses and empties the milk reservoirs without injuring the underlying sensitive breast tissue. Compress and release all the way around the breast, keeping the fingers at the same distance from the nipples. Stop expressing when the milk no longer flows or drips from the breast. Expressed breast milk can be stored at the room temperature for 6 hours, in the refrigerator for 24 hours and in the freezer for 2 weeks. Remember, do not squeeze the breast as this can cause bruising in the mother. Sliding the hands and not rolling them may cause painful skin burns on the breast. Avoid pulling the nipple, this may result in tissue damage. Hand expression can be very effective and certainly is the least expensive method. Never heat expressed breast milk in a microwave. If milk needs to be defrosted, place the milk container in a cup of warm water for a minute or two and then give it to the infant. Thank you.
Right. The babies require certain supplements also, like any other baby, vitamin K at birth. Babies who are less than 1.5 kg, because their requirement is much more than what milk can supply. So therefore, human milk is fortified with commercial fortifiers, which has got extra protein and calories and vitamins until they are 2 kg, and also they require iron and vitamin D. Babies who are 1.5 kg or more, they do not require fortifier, but they do require iron and vitamin D in the doses that are mentioned on the slide. How do you judge that the babies are receiving adequate amount of nutrition? You look at the weight. Initially, the babies lose weight 1 to 3% every day until 4th or 5th day of life. Maximum loss could be 10% or little more in preterm babies, particularly in very preterm babies. This can go up to 12-14%. They regain birth weight by 10th day, and then they gain weight at rate of 15 to 20 gram per kg per day in less than 1.5 kg baby, and 20 to 40 gram a day for bigger babies. And you monitor that by plotting the weight and head circumference and length on postnatal growth monitoring chart. And in this picture you have Fenton chart. On x-axis you have gestation, and on y-axis you have these parameters, and we plot it and then make sure that the baby stays within their lines. Some babies do not gain weight optimally, and then the causes could be low intake, like this can happen because of spillage in palliative feeding or inefficient breastfeeding in the when the baby is feeding directly by direct breastfeeding. There could be increased requirement as it can happen in cold stress, or sometimes because there is morbidities, so therefore baby requires more calories. Sometimes the mother is only giving fore milk. We know that the fore milk is rich in proteins but not in fat, so it is not able to supply requisite amount of calories. So the solution is that we make sure that the optimum volume is given. We make sure that the spillage is taken care of. If the breastfeeding is inefficient, then we correct the breastfeeding technique and supplement it with Paladay if required. Make sure that the baby stays warm and treat morbidities, and even provide extra calories if the baby requires so. There are other morbidities like sepsis and hyperbilirubinemia. We will not be discussing those because there is a talk for these things. There is a special morbidity which is known as retinopathy of prematurity. This happens in preterm babies because of oxygen toxicity, and that this ROP, if in some babies, can lead to retinal detachment and blindness. So these babies are screened. You can see that the baby is being screened, and some babies would require laser photocoagulation to halt. That you need to promote healing environment. This is very, very important. Do not cause any harm, because sometimes the harm in the process of caregiving is too dangerous and too costly for the baby. So we make sure that the baby is provided enough time for the rest. We do not disturb baby whenever we like. We cluster the care so that the baby can sleep. We minimize the light by covering the incubator, making sure that we do not make noise by the side of bed of the baby. We do not prick the baby unnecessarily. We promote breastfeeding, which is very healing effect apart from providing the nutrition. We make sure that the mother comes to the baby, talk to the baby, touch the baby, take the baby in the lap, provide KMC. So these are very, very critical things that one needs to do. Empowering the mother and the family is very important. We need to inform, educate, and build skills of the mother and transfer the care at the right moment. The mother should visit the NICU. She should get involved in care. She participates in decision making and supplies her milk. We teach her the danger signs like lethargy, refusal to feed, hypothermia, tachypnea, grunting, gasping, apnea, seizures, vacant stare, abdominal distension, and icterus over palms and soles. So those are very important. Vaccination is provided as per schedule, and we think of discharge when the babies are hemodynamically stable. They are not requiring any respiratory support, no desaturations or apnea. The baby is accepting feed by either Paladay or direct breastfeeding and gaining weight, and mother is confident in lactating, and then babies are at least 1.6 to 1.8 kg. We follow up these babies because there are variety of post discharge morbidities, and there is increased mortality in these babies compared to normal birth weight babies. They may require readmission because of pneumonia and diarrhea. There could be growth failure, and there could be neurodevelopment, hearing or vision related issues also. So follow-up care is provided to these babies, particularly those who are less than 1.8 kg and less than 34 weeks. We have a high risk clinic. Multidisciplinary care is provided. You have different people sitting out there so that everything can be provided under one roof, and you need to assess the nutrition and growth monitoring, take care of ongoing morbidities, assess and manage the neurodevelopment related issues, provide early intervention and family support. So coming to the prognosis, mortality, over 90% of these babies would survive with modest amount of support. So neonatal care, neonatal ICU care is very, very cost effective. You salvage a baby with modest amount of support, and then that baby has good quality life for next 60 or 70 years. So no other specialty has that kind of dividends. Mortality is generally inversely related to birth weight and gestation, and majority of them do very well. In long term, over 90% of them do very well. Major neurocognitive issues occur in 5 to 10% of the babies, and that depends on the birth weight and gestation, severity of complications. So if lower the gestation, higher the rate, higher the severity of complication, higher the rate. So now this is a quiz in the last for you. You can find the answer that you have a baby who's cyanosed when feeding or quiet, but becomes pink when crying. What could be the diagnosis? Thank you. Thank you very much. If there are any questions, I can take those up. Yeah, that's right. Coronal atresia. Good. Any more questions? If you have any questions, you can write an email to me and I would be more than happy to reply. My email is provided on the first slide. Okay. Can you please, we need to take attendance? Acha, okay, right, fine. Okay, okay, good. Hope that you are having a nice time in your hostel and at your home, and enjoy. Thank you. चलो जी, हो गया ठीक?
हाँ जी सर।